Welcome to Getting Better with Dr. Adam. Dr. Adam Silberstein is a clinical psychologist who has been working in the field since 1993. With a broad range of clinical experience, including state psychiatric hospitals, adolescent residential treatment with a trauma focus, the Department of Corrections, and in the addiction treatment arena. He is currently in private practice and is the clinical director and co-founder of Westside Treatment, a young adult dual diagnosis treatment facility in West LA. This podcast is for general information and entertainment purposes only. This should not be considered treatment advice, nor is it a substitute for an individual treatment plan. If you have questions or concerns about your individual situation, it is strongly recommended you consult a licensed professional to talk about things that are specific to you. If there is an emergency, it is strongly recommended you seek treatment at your nearest emergency room.
I just met with Dr. Josh Tal, a licensed psychologist. It was an honor to meet with him, one, because I've known him for so many years. I'm friends with his parents. And two, because I got to watch his whole career path unfold. And he has developed into an expert in sleep psychology. He trained at Stanford University under top clinicians and researchers. His writings have appeared in the Huffington Post and cityofsleep.com. He uses really, really cutting-edge treatments and has a tremendous success rate with people who present and come to him with sleep issues. I think you're going to enjoy and learn a lot about sleep. Hi there.
Hi.
I am so fortunate to have this very interesting experience. This is a first for me. Welcome to Getting Better with Dr. Adam. I have Dr. Joshua Tal, and he is a clinical psychologist and practices in Manhattan. But more interestingly to me is that this is the first time I am having a professional discussion like this with somebody who I knew when he was in high school. It happens to be that I know his parents and I'm friends with his parents. And I got to watch the evolution of Josh from a young boy in Los Angeles to a grown-up psychologist who has this funky specialty in sleep. And
yes.
And, so you guys know who are listening, I'm a little older than Josh. And when I was in training, the extent that we spoke about sleep was we spoke about it in the terms of how is your sleep in depression? If you're depressed, are you sleeping too much? Are you sleeping too little? We spoke about it in terms of nightmares and in terms of mania. Are you not sleeping? And maybe we asked if you had a hard time falling asleep, staying asleep, or waking up too early. And insomnia was this kind of, at least when I was in training, this kind of vague thing. So it was maybe secondary, and it wasn't primary, and it was this, you can have some issues that cause you to have trouble sleeping, and that's all I really learned in graduate school. And here now, many years later, there's a specialty. So there's so much to talk about here. Is that right?
Yes. And I love talking about it. So you have the right person.
So there's so much to talk about, but I figured we'd start with what does it mean to not have a sleeping issue? Who are the healthy sleepers? What do you look for in healthy sleep?
I mean, that's definitely an interesting question because surprisingly, many unhealthy sleepers do not really know what that means and do not know how to define it. And they think, their partner who can just fall asleep at the drop of a hat next to them is the healthy sleeper. When healthy sleep is sort of undergoing a bit of a revolution in terms of what that means. So healthy sleep means quality sleep, not quantity. Mm-hmm. And this is one of my big soapboxes. We've all been told about the magic eight hours of sleep, and that's been redefined recently.
So I don't have to, fight, to get, on the clock 10. If I go to bed at 10 p.m. and I get that 8 hours versus going to, to bed at midnight and I get the 6 hours, those 2 hours, like, oh my God, I'm going to be screwed tomorrow. You're saying it's not about the quantity, it's about the quality of the 8 or the 6.
Right. So, getting 6 hours or 5 hours consistently can be a problem, because even if it's a smaller quantity of quality sleep, you're still getting less quality sleep. But the idea is, are you sleeping? Are you getting those deep stages of sleep? So in sleep, there are different stages. There's different quality levels, and so there is shallow sleep and deep sleep and REM sleep, if I'm going to simplify it.
I want simple. I want so simple.
Okay.
So you do that.
Yeah, there's shallow sleep, which is just sort of the body running on autopilot, sort of like when you put your computer on sleep, like it's kind of on, but it's off also. And then there's like deep stage 3 sleep, where the body is sort of repairing its muscles and it's sending out growth hormones and other hormones to regulate the system. And then there's also REM sleep, rapid eye movement sleep, where we see a lot of the cognitive benefits of sleep, right? Where we see memory consolidation, and we see some of the processing of, we see like concentration skills building up and mood regulation skills building up. So we want healthy sleepers have good amounts of deep sleep and REM sleep. And good amounts meaning like at least 10% of the night is going to be in stage 3, and at least like 10 to 15% of the night is going to be in the REM sleep stage.
Can we back up a second? I don't know if people are listening are thinking about what is the value of sleep in general. Why does our species need sleep? And you're mentioning that it's more than just resting. Resting involves physiological repair or regulation, as a better word, and cognitive consolidation. So can you speak to that? What does it mean as a human, right? Why do we even need sleep?
Well, that's actually a really challenging question to answer, because scientists have not really come to a consensus on exactly why we need sleep. We know what happens when you don't sleep, right? We know that if you keep people awake, they kind of have a lot of issues, right? And people with insomnia can definitely attest to this. We know that sleep plays some part in temperature regulation. We know that sleep plays some part in physical recuperation and mental recuperation. But it does sort of bewilder scientists. I mean, when you think about it, right, sleep is one of the only things that doesn't directly protect us actively from physical or violence or anything like that has been preserved by evolution over time. Like, we're actually putting ourselves at risk when we sleep, but yet sleep is still a vital component of our active lives. And scientists have really not been able to answer that.
Right, because we're vulnerable. You're saying it's a very vulnerable.
Exactly.
It's vulnerable, but it's necessary, and obviously we know we can't be without it for too long, because we can go mad, right? We can really invite a certain madness when we don't sleep, and but we don't know exactly why, but we know there's benefit. And so to recap, you said that there's a certain amount. It sounds like it's about 25%. 20 to 25% of the total sleep should be in this stage 3 or REM sleep, right?
Exactly. It's 20 of the stage 3, and it's I believe I'm forgetting my numbers now. I think it's about 10 to 15% in the stage 3 and 20 to 25 in the REM sleep.
So
something of the sort.
So 40%. So
Mm-hmm.
so 40% of the total
Yeah.
sleep needs to be in these phases, and that's considered a healthy sleeper, right? So the
Yes.
benefits of a healthy sleeper, what will you expect if somebody gets an A in sleeping? What does that look like to you in terms of the psychologist evaluating them?
To me, so the American Academy of Sleep Medicine says that the normal amount of hours is going to be somewhere between 7 and 9 hours. We're going to see really the biggest metric in my book is how you're feeling the next day, right? Are you feeling overall well rested, right? Relatively well rested. You feel like you are yourself, that you have the energy resources to achieve the needs of the day. That is somebody who gets an A in sleeping in my book.
So
Funnily enough.
again, you're not talking. You sort of talked about quantity, but your emphasis is more on energy level, and do you feel like yourself the day after?
Right.
When you wake up, what is your energy level? So that for the
Exactly.
purpose of this conversation, we have just defined what healthy sleep is. So the next
Right.
question would be: so who comes to Dr. Tal?
So my normal clientele are the severe insomniacs, or the people who believe that that sleep is a big issue in their life, even if they are getting the amount of sleep, that I just described. So like between 7 and 9 hours, high quality, and restful the next day. So they perceive sleep as a big issue in their life, and I think the biggest metric of who comes to see me are the people who are thinking about their sleep multiple times throughout the day. Like, did I get enough? Am I going to get enough tonight? That to me represents a certain amount of anxiety around sleep, which often leads to wakefulness during the night.
So just like in a panic disorder, you're anticipating the idea that I don't want to have a panic attack. There's this anticipatory anxiety. In insomnia or in sleep issues, we haven't defined specifically which ones. The people who
Right.
come to you are anticipating problems, and it's not something that it's on their mind. It's a burden for them during the day. What's going to happen to me
Yeah.
at night with my sleep?
Yeah. Often I hear, right, that the morning is just shrouded in worries about how the sleep the previous night is going to affect the day. And then as the day continues, 2-3 o'clock rolls around, when there's a normal fatigue that affects universally everybody, almost a normal sort of dip following lunch, and that triggers, no, now I have to be worried about my night. Like there's a fear that almost like a fear that creeps up and says, oh no, I have to go to sleep tonight. What is that going to look like?
So
it almost develops into the fear of sleep itself.
So two aspects to it. One is I wake up, oh my God, I didn't get enough sleep. How am I going to function today? And as the day progresses, oh my gosh, what's going to happen tonight? What if I don't get enough sleep tonight? So this is it could be a burden throughout the day, throughout the day for these individuals who comes to see you.
Yeah. And often I see it's bleeding into their lives. It's bleeding into their social life. So they're canceling activities at nighttime. It's bleeding into their work. They're taking off days after a bad night of sleep from work. It's bleeding into their relationships. I mean, it's affecting usually many different areas of life.
When you say they're missing work, they're just too tired to go to work, or they're too tired to show up to events?
They believe that they're too tired. Well, so yeah, with work, it's like I had a really bad night. I know that when I go to work, it's going to be horrific, and I'm going to perform poorly. I'd rather just not go in at all. Usually, catch up on sleep a little bit is a part of it, and I'll go in the next day. So I see that a lot, and I also see canceling events. Right. So the usual approach to insomnia is the trial and error, misguided, unfortunately, approach to insomnia is, I'm not getting enough sleep. I need to give myself more opportunity to sleep. So I'm going to make sure I get into bed at 8, 9 o'clock. Mm-hmm. And I can't go out then to dinners with friends. I cannot do anything past 7. and thus, right, and then it just sort of that's part of what perpetuates the issue.
So I start
right,
to limit social engagement, not because I don't want to be social, but because I'm afraid of sleep.
Yes, exactly. And I want to give myself the best chance to catch up on sleep.
So this term catch up on sleep, right?
Mm-hmm.
I know a lot of we come from a place where Saturday naps are a big thing, right?
Oh yeah.
And this napping is I can't wait for that nap because I get to catch up on my sleep.
Mm-hmm.
I've always wondered, what is that? Is that a real thing? You're talking about these individuals wanting to catch up and missing obligations and missing work. What is catching up on sleep? Is it a thing?
I think some people. It's hard to say. There is research that has shown that it is not a thing. So that when, for example, something I often see is people who limit the amount of time in bed, so I don't see this in my clientele, but I know people like this that they are. Oh, I'm going to sleep for 5-6 hours during the week, and then when the weekend comes, I'm going to catch up on sleep over the weekend. That you can never catch up. That you do not get back the hours that you miss, and you do not get back the health benefits and the cognitive benefits from limiting the amount of time you're sleeping.
So there's no banking system. There's no I can sleep too much, and there is no, the credits don't transfer to the next day.
Right. There is, right, in terms of the benefits of sleep, but there is, right, so there is something called, right, like what we call like a sleep drive. So it's sort of like an amount of tiredness and fatigue that is separate from the cognitive effects of sleep or of insomnia. So there's like a tiredness, a drive. It's similar to hunger, right? So as the day goes on, your tiredness, your sleep drive builds up. And if you're getting poor nights of sleep, you're going to be more tired. And so if you take a nap or something, you reduce the amount of sleep drive that you have through the day. Now, this for some people could be good because they might be inordinately tired, which would be a problem. But for people with insomnia, usually the catch-up nap can actually reduce their sleep drive to a bad level where then they're not tired for bedtime.
So Dr. Tal is not making a statement.
Balance.
Dr. Tal is not anti-nap. He's not saying a blanket statement anti-nap. He understands that the nap could be an energizer.
Yes,
right? He gets it.
If it's at the right time and the right length, yes, it can be.
If it's at the but for someone who has a real sleep issue, it may be an aggravator of the sleep issue itself.
Yes. Someone who has an insomnia problem, it can be a perpetuator.
Okay. So on a similar note, we're talking about catch-up sleep. Is there such thing as sleeping too much to you?
Yes. So I do not often see people who sleep too much, as you can imagine. Sleeping too much usually can be a sign that there's not enough quality sleep, right? That so it can be a sign that there's an underlying undiagnosed sleep disorder. It could be a sign of, right, so we're talking about, it could be sleep apnea, which is so like pauses in breathing that are taking place at night that are keeping people from those deep stages, or restless leg movements at night, or teeth grinding at night. It could also be a sign that there is a sort of right, like narcolepsy, so like nap attacks and things like that. So that's another underlying sleep issue.
So all of these things have in common, they're disruptors in the effective sleep quality. They're all disruptors, and that could be a sign of sleeping too much. What do you define so it's not about hours, just like it's not about specifically about hours, but it's about quality of sleep being impacted again. And if somebody's sleeping 12, 13 hours a day, right? And they're not an infant, right? There could be there could be an issue of quality of sleep. What about substance? Does that
right? So that's the other thing, right? So it could be a sign of right something else interrupting the sleep quality, such as substances. We know that, right, alcohol and pot, marijuana, people usually think that they're actually great for helping get to sleep. And there is some evidence that it does help people get to sleep. But again, the quality is poor. So they found that even though there's a faster latency. So you can fall asleep faster when you're drinking alcohol. You're actually not getting any of the benefits of the deep sleep. So it's actually robbing you of the growth hormone. It's robbing you of the issues. And then the second half of the night, you have tossing and turning and dehydration and things like that.
So I know we're doing a lot of bouncing around. I kind of like it. The substance, marijuana, the substance, alcohol. What about sleep aids like Lunesta and Ambien, or people who use Xanax, benzodiazepines? What's your position on that in terms of help? Because it definitely helps people fall asleep. What's your take on those agents?
So the official studies on these medications have said that it's mostly a similar quality sleep, and it's healthy sleep. My position is based on my clients' sort of anecdotal evidence, is that it actually can lead to poor quality sleep, and it can lead to other issues. I found that when I used to be actually a sleep technician in my parents' sleep lab, and that's actually what got me into the sleep world.
Tell us about that.
Yeah. So when I was in college, my parents opened a sleep center, and I was trained as a sleep technician, or what's called a polysomnograph technician. And essentially, I would stay up all night helping people sleep, ironically. And so I would have.
So you got insomnia to help people sleep?
Yeah.
Cool.
Yeah, and so it would be like a circadian rhythm issue. I'd come in at like 8 p.m. and I'd set people up with brain electrodes and electrodes all over their body, breathing sensors and things like that to diagnose, right, those sleep quality issues that I had mentioned previously. So that's why they were coming over, because you never know if you have a sleep quality issue if you're not measuring brain waves and bodily functions, right?
I don't know. Can you explain what you mean by that?
Yeah. So like if somebody has something that is interrupting their sleep in the nighttime, it can wake you. So for example, apnea, pausing and breathing, which has its own health issues. But in terms of sleep, it can wake you up from a deeper sleep to a shallow level of sleep. So you would never know, hey, I'm waking up throughout the night because I'm not breathing. Oftentimes, people with sleep apnea don't know that they have it because they're not fully waking up. They're just going into the shallow levels of sleep more often. And it's actually, sleep apnea in particular is 85% around undiagnosed. So there are 85% of people that have it do not know that they have it.
And they're just tired. They're exhausted. And
they're just tired. Yeah, they're just tired. And it's wrecking havoc on their lives without them knowing it.
So in this training that you had, because of your parents, not because of your training in graduate school, you really got to see on the ground how you measure, you can actually see the measurement of sleep quality with electrodes, what percentage of sleep is in the shallow sleep versus the more restful states of sleep.
Exactly.
So you really, you were on the ground in the diagnostics.
Yes.
Oh, wow.
Yeah. And I would score the studies also and help, so that the MDs could diagnose the issues. But so what I was saying earlier is, the reason I brought it up is because I would see clients who were drinking or taking the benzodiazepines or the Z drugs, right? Ambien or Lunesta are called the Z drugs. So I'd see them, and oftentimes I would see, even in the deeper levels of sleep, I'd see intrusion of wakefulness often, which are called beta spindles. So I'd see, beta activity is what we actually, our brains, when we're awake, we have beta activity. We have the electrons firing all the time. And so I would see beta intrusion in the middle of sleep because, and I'm not an expert in the exact science behind the biology in the brain with sleep, but I can tell you it did not look like the best quality sleep.
So the myth, and I've heard this too. I've heard that, I actually have a brother who's certified. He did a fellowship in sleep medicine, and he's not anti-meds. This is, and again, I'm also not an expert. He's saying in short term, he's okay with it. He's concerned about more long-term use. It's a good starting point, but the more long-term use in his as he's explained it to me, invites this wakefulness like you're talking about.
Exactly.
And you saw it firsthand. So a lot of people will think that they're sort of, using the alcohol to sort of unwind and get to sleep. And it may not be the best for the quality of sleep.
Exactly. And the issue is that's a lot of times I see in my clients that they'll come to me, will help them get more hours of sleep, and they will titrate off their medicines, under the supervision of their prescribing doctor, and it's like a veil is lifted off of them, and they are more alert and more awake, and they're just feeling great, even if they don't actually increase the quantity of sleep by that much. Even if it's just an extra half hour, they are feeling fabulous, and they actually often tell me, "How come no one told me about this?"
Wow.
Like, why I've been on Ambien, I've been on Lunesta for years, for decades.
Wow.
And my doctor just gave me the script, gave me the prescription. No one told me about cognitive behavioral therapy for insomnia, the treatment that I do.
Let's back up in terms of the people who come to see you. So we're learning a lot about sleep and about the different impact on from quantity to quality and how it affects you during the day. So if I'm going to come see you, it's not because somebody said, hey, you're supposed to be getting 7 hours, you only got 6.5. I'm coming to you because I'm suffering. And I'm in this cycle of concern that I didn't get enough sleep and I'm not going to be able to function, and then fear that I'm not going to be able to sleep at night. So the typical patient who walks in to a sleep psychologist is really impacted, but it's the individual is off their game because you're talking about they're not able to honor their obligations and they're limiting their life. It's so impactful. So tell us a little bit about who walks in and what you do with them.
Right. So the biggest thing, right, it's exactly what you described. It's somebody coming in and saying something is wrong with my sleep and something is wrong with my approach to sleep. And I think I have insomnia and I need to figure this out because it is ruining my life. Right. In those words or other words. The biggest question that I first have though is the question is this actually insomnia? Right. Because even though they might be have difficulty falling asleep or difficulty staying asleep or issues waking up too early, it may actually be a different sleep disorder that is masking itself and looking like insomnia.
For the purpose of the audience, and the audience, by the way, is both clinicians as well as other people, just interested parties. What is insomnia to you by definition?
Right. So insomnia to me is somebody who has difficulty falling asleep, difficulty staying asleep, or difficulty with waking up too early, and it's become chronic, right? So it's at least 3 nights a week, right? And it's been going on for quite a while. So new DSM, so Diagnostic and Statistical Manual for Psychopathology, says that it's going on for at least 3 months, right? Because what we're talking about is a chronic issue, right? So that it's bad, you're not getting enough sleep, and it's affecting your life. So the other qualification would be that it's causing significant distress, or it's impairing your functioning in some way, right?
It's going to make you cranky the next day. It could make you low energy.
Right. Yeah. I mean, more than that, it's right. You're not going into work, and you're causing a lot of issues going on, right? In your relationships, just like I mentioned earlier.
So that's insomnia, right? That it affects the quality, not just your sleep, but the quality of your life in many ways. And but you're saying you come in and the patient assumes I have insomnia, and you're like, whoa, I know what it is, but not so quick. Let's look. I'm not just gonna sign off insomnia, so I'm not gonna just endorse that diagnosis so quickly. It may be other things. So what are the other types of things that you and the underlying issues that if it's not insomnia, what could it be?
Right. So the main things that I'm looking out for. So the first is sleep apnea, right? I mean, sleep apnea can look like insomnia, or it can be combined with insomnia to be an issue. So, for example, if somebody tells me, if I fall asleep quickly, but then I wake up around 2-3 in the morning, and I'm awake for a couple hours, and not only that, I'm so tired in the day that I catch myself falling asleep in meetings, right? That to me would be a sign. Okay, we need to rule out insomnia. We need to rule out sleep apnea before we continue, because likely what is waking them up could be actually sleep apnea. And so the clues to me would be around 2-3 in the morning is usually when we enter REM sleep. And REM sleep is usually when the apnea events are the worst, because in REM sleep, our muscle tone in our body actually turns off, meaning our throat muscle tone could actually turn off, and that's when we see the cessation, the most cessation in breathing, the most breathing events.
Interesting.
Right? And the same at the same time, right? Someone who has insomnia is usually not falling asleep in the middle of meetings or in passive activities, right? Someone with insomnia is getting less sleep, but there's a certain amount of vigilance during the daytime and anxiety during the daytime that attends insomnia, that keeps them awake.
It's almost like like an energizer.
Exactly.
The insomniac will have an energizer of anxiety. I'm afraid I'm not going to fulfill my obligations.
Exactly.
Whereas the apnea
same system.
Yeah.
Very the same system that keeps them awake at nighttime is actually ironically keeping them focused during the daytime, much to a point that people with insomnia don't even realize.
What do you mean the same
they're
system?
Actually functioning. So the same arousal system, the same fight or flight system, the anxiety system that is keeping people awake in the nighttime is actually increasing in the daytime as well, to help them attend to their issues. And clients with insomnia actually routinely overestimate the effects of their sleep on their day-to-day.
Interesting. We'll get to that. Remind me, we're going to get to that. What other issues do you see if it's non-insomnia? We spoke about apnea.
Right. So it could be apnea, or it could be restless leg syndrome, or bruxism, teeth grinding, like I mentioned earlier. I also look out for a circadian rhythm disorder, which is not the same.
By the way,
insomnia.
There's no way, just your typical clinician knows what. No, I mean, listen, I shouldn't say there's no way. I'm guessing that circadian rhythm issues are not on the tip of most clinicians' tongues. I don't think they are, but at least maybe I can speak for myself.
Yeah, but it is. I mean, I think you'd be surprised. I mean, right? How many times do you pick up on, if a client is like more of a night owl or a early bird, right? And if that's causing issues, that's what I'm talking about, right? So we're talking about like somebody who's a night owl, right? They're staying up late, and right? They might think they have insomnia, right? So someone with a delayed sleep phase syndrome might say, oh, I get into bed at 11 and I toss and turn until 2 and I can't fall asleep. And then I say, what time do you wake up in the morning? 10, 9, right? So they're sleeping a decent amount, but they have almost like a permanent jet lag, right? So they're going to sleep on. So the example I always use is if you're in New York, you're going to sleep on LA times and you're waking up on LA times. So if you lived in California, you would actually have a perfect sleep schedule, but you live in New York.
Interesting.
So we have a problem.
Is that,
right?
just out of curiosity, what is the treatment plan for that? How do you treat that?
Completely different. It is completely different. So with somebody with a delayed sleep phase syndrome, it depends how bad it is. So if it's within 1 to 4 hours of a delay, you're going to be looking at light therapy and melatonin supplementation. Now, melatonin is not a good sleeping pill, but it is really good for helping with circadian rhythm issues. And usually, I cannot recommend melatonin use, but usually I can point people to some online resources which talk about administrating melatonin actually 2 hours before the usual time falling asleep, and then moving that back slowly over time until you're at the bedtime.
Just to educate the audience, can you just speak for a minute on what it means to have what is the circadian rhythm?
Yes. So the circadian rhythm, this is something I go over usually in my initial first treatment session, is the circadian rhythm is an internal clock inside the brain. And essentially, it runs on a 24-hour cycle, and it dictates to the body using hormones when we should be awake and when we should sleep. So it's a clock. And what's cool about it is that it is actually runs on its own. So the brain uses light and human interaction to set the clock to say to the clock, it's daytime, be awake, interact. And when our brain sees that there's less light or sees that there's less events or interactions, the brain shuts off the wakefulness hormones and we go to sleep. But the clock does function on its own. So if we put you or somebody in a completely dark room, pitch black, you would actually fall asleep and wake up at similar times to when you're outside of the room. So the clock can be set and it runs, and that's why we have jet lag, because we go to so like for somebody in New York, they're on New York time, they're going to sleep and waking up. Most people, right, are going to sleep and waking up at the same times in accordance with the nighttime and the daytime. And then you go to California and you are and 9 o'clock rolls around California time, Pacific time, and you are feeling tired because your clock is still set to New York. So 9 o'clock in California would be 12 o'clock a.m. in New York. So your circadian rhythm is set to New York, but if you're in California, then there's a mismatch. So
you restore that with light. Just a question: do phones, does excessive phone use impact, because of the lights, impact circadian rhythm?
Right. So in the general sleeper who is potentially a good sleeper but not an excellent sleeper, and is finding they have some mild mild issues sleeping, and then the light might help them. So meaning the light might be hurting them. So looking at phones nighttime may be affecting the circadian rhythm and telling the brain that it is time to wake up. It really should be time to go to sleep. I actually find that the content on the phones or on TV are more of the issue. And for somebody, so meaning checking work email or checking email or watching a thriller, like on TV. Like I found that I used to watch the Game of Thrones,
Mm-hmm.
and I could not fall asleep for at least an hour.
Too exciting.
After watching the game. Very exciting. So I think that is the culprit, less about the blue light. And definitely for somebody with insomnia, I mean, most people with insomnia that come to see me have tried this, tried blocking out the blue light, tried wearing the amber glasses or putting the filters on their phone. And that will not cure insomnia. Okay. And that will not cure a circadian rhythm issue.
So let's talk insomnia.
More of a sleep hygiene.
Let's
issue.
talk insomnia, because that's probably after you've ruled out different issues. I would imagine insomnia is a lot of.
There's one more I want to rule out, though.
Sure.
One more I want to mention, which is not setting enough time for sleep. Okay. So some people come to see me and they'll say to me, "Oh, doc, I need help with my sleep," but they're actually going to bed really late and waking up too early. And there's nothing I can do for that. That's just not setting enough time to sleep.
It's not sensible. So like, hey, I'm really struggling. I went to bed at 4 and I had to wake up at 6. I'm trying to do it every night.
Right.
Can you help me? You're like, no, I can't.
Can you help me?
Yes.
And like, go to bed earlier. Like I feel like that's what you have to do.
By the way, I just want to say for the record, you make sleep very not boring. So it's very, I was like dreading this. I'm like, am I going to be bored, yawning, talking about falling asleep, talking about sleep? But you make sleep come alive.
Well, it is super not boring, and I actually take offense that you thought that.
That was the story I told myself before. This may be a tough one. But there's so much to talk about. So suffice it to say, I'm assuming a lot of the people have insomnia, and there are all these sleep I see in the world of meditation apps. Even at the gym I go to, I see like a lot of sleep meditation and so forth. And to help with your insomnia and to help you get to sleep and stay asleep.
The sleep aid industry, $63 billion.
Wow.
In sleep aids, sleep meditations, mattresses, all different sorts of things. $63 billion.
$63 billion industry. So they still come to you,
and
despite the big industry.
And it's growing by 8% too every year. That's what they're saying.
For those investors, Dr. Tal is saying it's a growing industry.
Yes, it is. The growth industry.
So they have a lot of the people tried all these apps and
Oh yeah. All the clients I get have tried everything, and that's part of the problem too, right? Is that they're just spiraling. They're trying. People with insomnia tried everything. Every person, right? Insomnia. This is part of the problem. Insomnia is like an easy badge to wear. Mm-hmm. An easy cross to bear, and it's great conversation because it's a little bit of you're talking about mental health. It's kind of taboo, but it's also like socially appropriate.
Right. It's not talking about trauma. It's not a specific trauma. So tell me
like I'm depressed.
So what's the person who comes to see you? What is it going to look like for them to get better?
So usually, right, the person who comes to see me has tried everything. And because of that, through trial and error, they've developed two general bad habits, right? So they have these issues, and because of it, because they've had some bad sleep for a while, they begin to worry about their sleep. So that's bad habit number one, right? Mm-hmm. Worrying is an extension of problem solving. And it essentially, right, makes us feel better in the short term, but actually hurts us in the long term. So worrying about sleep causes people with insomnia to stay awake.
Hold on, right? Did you say it actually? It may be something that provides relief, but ultimately is not serving the sleep. Okay.
Yeah. So worrying about sleep, our brains get tricked into thinking that when we worry about something, we're actually being productive, but we're not usually. And usually we don't actually even employ what we learn when we're worrying. And so we worry about sleep, or people with insomnia worry about sleep, and they get into bed and they worry about sleep, and that keeps them awake. So that's bad habit number one. And bad habit number two is taking that worry and sort of imbuing all the actions around sleep with that worry, right? Mm-hmm. So getting into bed earlier and meditating and right, supplements and doing all these haphazard attempts at fixing the sleep, and all those actually become an embodiment of the anxiety, and they actually reinforce the anxiety instead of leading to sleepfulness.
So they may have rituals and certain ideas that I have to do to be. My worry is telling me I have to do this to be okay.
Right.
But in reality, the worry becomes the problem, and they actually are okay absent those activities.
Oh yeah. And so usually that's what I see, and more than that, right? The bed becomes a big culprit, right? So going to bed earlier, staying in bed in the morning later, and tossing and turning and becoming anxious leads the bed to become, right, a conditioned stimulus, meaning that the bed itself triggers the anxiety. So someone could be very, very tired, and then they get in bed and they're wired, they're wide awake. Why is that? Because the bed itself becomes a trigger for the insomnia, that it takes on the actual anxiety to cause the insomnia.
So you unpack this and you're like, hey, you're a big worrier. You're worried.
Yeah.
And the worry isn't just worry about work. You're a sleep worrier. So the people who come to see you are sleep is their biggest worry.
Yeah.
And you are saying to them, you're saying all this stuff you do, I know you think it's helpful, but it's actually reinforcing the worry.
Right.
So how do you help them to get relief?
Yeah. So what I do is the first thing I do is, so what I do is a treatment called cognitive behavioral therapy, right? So I'm going to be looking at the cognitive component, the thoughts about sleep, right? So the anxieties about sleep, and the behaviors around sleep. And what I do is I usually develop a behavioral system to reset the body and the mind's connection to sleep, and at the same time challenge the worries about sleep.
How much of this is, you've taught us so much in the time we had about sleep, what sleep is, what sleep isn't,
right?
What's healthy sleep, what's not healthy sleep. How much for the individual who's tried everything, how much of what you're doing is just a basic education? Because I hear you saying you're alerting them, hey, everything you think you're worried about, let's pause this. You actually may not need to worry about this, especially if you have insomnia, because you're not going to die.
Right, exactly, right. How much is worrying? How much is education? I spend the first session, the first treatment session, doing education, and I will cover the sleep drive system I alluded to earlier, the circadian rhythm, and I will cover the fight or flight system and how they all work to either help sleep or hurt sleep, and then I'll talk about conditioning and how the bed becomes a stimulus for bad sleep. And then I'll develop the sleep behavioral plan, or what I call sleep boot camp. And from there, it becomes an experiential system where clients are going to be, I can't just tell them, oh, sleep doesn't matter and you're going to be fine the next day. Right. They have to experience that to learn it. So essentially what I do in the sleep boot camp is have them, in summary, I have them sleep a little bit less so that they are resetting their sleep system, and at the same time testing their worries about sleep if they're actually true, right?
So two things. One is the actual retraining of sleep, and the other one is the anxiety that has developed over time to help relieve the anxiety. So you're doing two things at once.
Yes. Mm-hmm. And then I build in other components as necessary. So relaxation training, or really more direct worry challenging, or things like that. So the idea is, right, so for example, somebody comes to me, they're in bed 10 hours and they're sleeping 6 hours, right? I see this a lot. What I do is I have them be in bed for about 6 hours, And then I have them gradually, so over time, right, they're in bed for 6 hours. This is a very, very scary thing for someone with insomnia.
Right, they're probably
So
terrified.
it's very terrifying. So that's why I spend the whole first session with teaching all the elements of sleep, because I'm a very transparent therapist, but I really want them to understand what they're doing and why they're doing it, so that they are not just using blind faith to do the treatment, so that everything is really understood. And then so they're in bed and they're not sleeping. So they're in bed for 10 hours. So I have them be in bed for 6 hours. And the first few nights, they're not sleeping very well. But the third night or the fourth night, they get into bed and their sleep drive kicks in, and they sleep 6 hours straight, or 5 3/4. And then the following night, they sleep 5 3/4 hours. But instead of sleeping in and oversleeping to compensate, which people with insomnia usually do, they're just sleeping that restricted amount of time in bed. And the following nights, so the following week, so every week, I will analyze the sleep data, and I will hopefully increase time in bed and fill out the bed with good quality sleep,
instead of tossing and turning and generating anxiety. And what kind of results are you seeing?
Oh, I'm seeing amazing results. It's amazing. So the treatment itself, in the research, has a wonderful research base, which has so the research itself has shown that 85% of people that do this treatment fully, and we're talking about 5 to 8 sessions, right? 85% will get at least an hour of sleep or more. And
An hour increase.
An hour increase. Yeah.
Okay.
An hour increase. And I've seen in my personal practice about 90 to 95% of people getting at least an hour or more. And I've seen, 95% reaching the goal that they set out to when they come to see me.
Okay.
It is incredible.
That is so unbelievable. And
I know I don't even believe it myself.
It's not. I don't know if it's good for business because you don't have a long-term customers.
It's a horrible business model. Horrible,
right? Because they get better. They get better.
Yeah, they get better.
So let me throw out a case where I think that sounds more challenging to me. That isn't just a 5 to 8, but more like what are we going to do? Somebody who's had a trauma, like a horrific trauma, and has either nightmares or impact of a traumatic event that's affecting their sleep. You ever see that?
Oh, all the time, yeah. So in general, right, so the 5 to 8 quote is what I say is usually right for just insomnia, right, or insomnia and some mild depression or mild anxiety issues, right? But if there is a whole other underlying pathology like trauma or a full depression or a full anxiety disorder, right, which is part of the other things that I'm looking for in the intake, then treatment will be a bit longer. And what treatment, so somebody with trauma, what I sometimes see is that there is it's not even, it's less about an anxiety around sleep, and it's more about there's fear at nighttime. There's part of their brain is not letting them fully engage in sleeping for fear of what might happen.
Interesting. Now, did they have fatigue during the day? Like the apnea person you were saying is going to be tired. The insomniac is going to be more aroused and alert. You're talking about someone with trauma. Sounds like more of an arousal response. So it's not going to cause them to not sleep.
Right. It is. Right. So the arousal response will be there in the daytime and in the nighttime, right, keeping them awake. But it's a significant amount of arousal. It's a vigilance, right, attending to anything that could be a threat. And it kind of reminds me of how dolphins sleep, right? Where dolphins, you'll have, they sleep where half their brain is asleep at a time and half their brain is awake. So you never see them fully asleep. They're just always swimming around. And so someone with trauma will have almost like a quarter of their brain, and this isn't substantiated in science, but it almost feels like a part of their brain is staying awake to make sure nothing goes wrong.
So how do you create sleep for that? How do you help facilitate sleep?
Well, it depends, right? If I'm working on if we're working on the PTSD or the trauma, the post-traumatic stress disorder, or the trauma, as well as the sleep, then treatment would be focused on helping the clients build safety again and build skills and engage in life again. And that would, in turn, help with the sleep. I would not likely do a very intense sleep boot camp or restriction because, in general, you want to be taking care of safety and protecting against safety with the clients. And you don't want to be pushing clients overboard with their issues. So someone with trauma, I would likely, if we're working on the sleep itself, then I would let them have a little bit more time in bed than I would usually with other clients. But if I'm just focusing on the insomnia, then the treatment usually is a little bit longer and a little bit of takes a little bit longer to really let go of that vigilance in the nighttime. But treatment results are pretty similar. And in turn, I believe there was research going on through the VA hospitals that showed that treating the insomnia in trauma syndromes actually helps decrease the trauma scores, right? The trauma as well, but not to a level where it goes away, but at least takes it down a notch, as you can imagine.
So we're wrapping it up. There are a few things I want to sort of throw out. I'll talk about me for a second. I told you this, that I am a person who can wake up. I don't even need an alarm clock. You tell me that you need me to wake you up at a certain time. I was just away on a trip, and my nephew said I need to be up by 9. Once he put that in my head, we all went to bed late. I'm up by 9, waking him up.
Wow.
I'm really into this master swimming thing. It's my new favorite thing. I have to
Cool.
wake up at 4:30. I'm up at 4:30. I can set the alarm. It doesn't matter. I'm going to get up. Like a soldier. What is that?
That's amazing.
Just a lucky guy?
Yeah, I guess so. I'm not exactly sure what it is.
I'm fine. I'm rested. I wake up. I'm excited to get up. I don't even have a turnaround, but I'm saying I obviously don't need a sleep psychologist. I think I don't.
Yeah.
I may be a psychologist for other things, but at least not for sleep.
Mm-hmm.
So,
wow.
Have you ever seen that, just out of curiosity?
Yes, I've definitely seen that. Oftentimes what I'll see is clients waking themselves up earlier than they want to, no, no, so I don't really see it that often in my practice.
Well, I'll take it. I'll take it.
You should enjoy that.
So 2 more things. If you're going to say to the audience, here's some tips to get an A in sleep,
yes.
right? What do you say to them?
Number 1, don't worry about your sleep. Right? You don't want an overemphasis on sleep, especially if you already have a sleep problem. If you make sure you're setting enough time to sleep, but if sometimes you don't get enough sleep, it's okay. You'll be fine, right? What I say to clients often is you don't want to live to sleep, right? You want to sleep to live. And so take the emphasis off of, am I getting enough sleep, and focus on, building a life that's worth living.
And chill out about not sleeping. You'll be
chill
okay.
Out.
Chill out. That's message number 1. What's message number 2? To the general sleeper.
Message number 2 is general sleeper is right. Look into your sleep. So if you find that you are having a casually look into your sleep, because if you're having issues sleeping, don't just jump and you're feeling tired during the day, it's worth checking out. It's worth getting a sleep study and figuring out if you have a sleeping issue that's underlying, right?
So, and you would go to a sleep medicine doctor for that, correct?
You could go to a sleep medicine doctor. There's actually online companies that will send you a home sleep test, and you can send it back to them, and they'll score it and give you a report.
Okay.
So that's
message number one, chill out. Message number two, in a chilled out way, do some self-examination. Don't freak out and get yourself a sleep study. Final question. So for some of the people who are going to be listening to this are therapists and like me have probably learned a lot about what sleep is, what sleep isn't, what kind of problems you can have. There's a whole host of things. What would you say? When is the time for your typical clinician to say, hey, it's time to refer to a sleep expert?
So I think the time would be when you've tried a host of things. So most clinicians know what sleep hygiene is and have tried a couple different things with sleep hygiene. Have tried telling clients to get out of bed when they're not sleeping, and tried looking at coffee intake and substance intake, and I've sort of exhausted it. And most of the time, when I get a referral from another therapist, they in general don't want to be talking about sleep the whole time, and they're finding that it's dominating the conversation a little too much, and they want to focus on what they feel is more of the critical other issues. Mm-hmm. And so then they can send them to me
because they get bored because they're not excited about sleep like you. They're bored. You're excited about sleep. So that would be a very good lesson to me in this is know when it's time to say, hey, you need a different type of care to treat this specific issue.
Right.
So,
and it's really time limited, right? It's 5 to 8 sessions. Most CBT for insomnia therapists will, they'll treat them and send them right back. So there's no issues there.
I love it. And I just want to say this was Josh Tal, this kid I knew, now this decorated sleep expert in Manhattan, not even in LA. What a wealth of information you gave us. And it was great to talk to you. And I hope you have other areas of expertise that you build so we can talk to you again.
Oh, yeah. Oh, I want to add one more thing.
Please.
If that's okay. Please reach out to me if you need a sleep referral. I am connected to a ton of sleep experts, and I'd be happy to find one in your area.
Oh, interesting. So even though you're in Manhattan, right, it sounds like this is kind of like a community, the sleep experts. You're part of that community. So if anybody needs a resource, they can reach out to you. Do you want to give your contact information?
Yes. So my email address is Dr. Joshua Tal, so DrJoshua, T as in Thomas, A-L as in Lima, @gmail.com.
Mm-hmm.
And so you can reach out to me, and I would be more than happy to find a CBT for insomnia expert in your area.
And we're also going to put this on our Instagram page, and we're going to put this information there too, as well as your phone number, I believe. So if anybody wants to reach out for a resource, please feel free to. I encourage it. And again, thank you so much. That was great.
Sure. Thank you for having me.
All right. I loved it. I'll speak to you soon.
Okay. Bye.
This podcast is for general information and entertainment purposes only. This should not be considered treatment advice, nor is it a substitute for an individual treatment plan. If you have questions or concerns about your individual situation, it is strongly recommended you consult a licensed professional to talk about things that are specific to you. If there's an emergency, it is strongly recommended you seek treatment at your nearest emergency room.